I must admit that when this subject was given to me, I felt a little bit uncomfortable. Because if Xavier has said that he had a lot of difficulties finding out in the PubMed studies addressing the outcome of patients where the work of breathing was measured, for what concerns the monitoring in non-invasive ventilation is much, much less. And you see, what you have heard up to now here is not applicable or is only in part applicable. We are dealing with patients who are conscious, more or less collaborative, whose interface with the mechanical ventilator is not an endotracheal tube, but is something else. And so applying the conventional monitoring is not that easy. I try to apply a sort of systematic approach to give something that may be logical, maybe something that is more good common sense, evidence-based than evidence-based medicine. And then we have 4 fundamental approaches: physiological, subjective, objective, and clinical. In what consists the physiological approach? The measurement of continuous oximetry and capnometry, and we'll have a couple of considerations concerning that. The exhale, tidal volume, and the potential desynchrony that should be useful to be monitored, but I will not insist that much on that because Philippe Choyer will detail this issue. Then the arterial blood gas analysis, the classical approach that can be taken 1 hour immediately after the application of non-invasive ventilation or as necessary at a given specific time. And then lastly, the work of breathing. I put there for research, even though nowadays probably there will be new applications due to the fact that is going to be introduced in the market a new type of NG tube that can allow the feeding of these patients at the same time measurement of esophageal and gastric pressure. If you look at the physiological variables, the 2 that can be measured by a non-invasive device are the continuous oximetry and capnometry. But I don't want to insist that much on continuous oximetry because there are a number of studies that show the reliability. I would spend some few words on capnometry. You know that this is a reliable way to measure transcutaneous CO2 in children, but the applicability in adult patients is quite questionable. I want to give you a couple of examples. This is one of the papers that was recently published and addressed patients that were admitted to the emergency room, in large part patients that may be candidate or received non-invasive ventilation. And if you look at them, there were collected 29 pairs of simultaneous measurements of transcutaneous CO2 and arterial CO2 in 21 consecutive patients under these conditions. And if you look at the Blond and Altman analysis, you can see that there is a good correspondence, even though there was a range between 23 and 84. And the mean difference between PaCO2 and PaTCO2 was low, with limits of agreement that were quite satisfactory. And the correlation between the PaCO2 and PTCO2 was good. But if you refer specifically to conditions where non-invasive ventilation was applied and where there was a systematic measurement of PaCO2 and PTCO2, you can see that there is apparently a good correspondence of the values between these 2 kind of measurements. But unfortunately, if you look at the Blond and Altman again, you see that for having a good correspondence, you need to correct for a drift of this variable. So probably the message would be the measuring the PTCO2, the delta PTCO2 can be valuable. Don't look at this as an absolute number that can be obviously erroneous. But however, by using certain interfaces such as the helmet, where, as you know, the CO2 rebreathing is a function of the flow, the passing through the system and part of the production or the CO2 production of the patient, it's strictly important having an adequate flow there. But you cannot have hemogas analysis, the measurement of a CO2 of the tissue CO2. And having the transcutaneous measurement here may be, to some extent, useful. What about the exhaled tidal volume? It's relatively easy when you look at patients with a facial mask. You can rely upon the numbers that you see on the screen or your mechanical ventilator. But if you have leaks, that can occur some interesting phenomenon. And having the possibility to monitor the respiratory curves on your ventilator may make a difference. Indeed, when you have an air leak, can occur the so-called hang-up phenomenon. You know that if you are under pressure support, by cycling off the ventilator, you need to have a decay of the initial inspiratory flow. In presence of a leak, what happens? That machine perceives the presence of this leak as a further requirement of flow on part of the patient and continue to give to the patient, and the patient is unable to cycle. You may attempt several different possibilities, and if you don't have a ventilator where you can adjust, for example, the expiratory trigger, and you have an old ventilator, as first having the flow tracing and the airways tracing, here you can see also an esophageal tracing, may be very useful because immediately you realize the situation, and then you can adopt a strategy that with all ventilators may be useful. For example, shifting from the flow cycling to the time cycling in pressure control, and avoiding these major inconvenience also in presence of air leaks. But if you can measure volumes easily with the mask, this is not easy at all when you have to look at the helmet. Why? Because part of the pressure that is given to the patient is spent to distend the helmet and to allow the ventilation. But you cannot rely upon at all on the numbers you see on your screen. And so, in principle, you do not know what the tidal volume, expiratory volume is. There are options. For example, this one is the optoelectronic pletysmography. This was applied in the early 90s by Ferrigno in Journal of Applied Physiology, and consists in a system that is an optic system with a lot of sensors placed in the upper, lower thorax and the abdomen, and can give a sort of partitioning of the volumes distributed by the upper, lower, and abdomen. But if you have to instrument a patient like this, and we did that for measuring volumes, it is very difficult out of the research setting, because if you have to do that clinically in a patient who is spontaneously breathing and he interacts actively with you, believe me, it's not easy at all. However, having a balloon placed into the esophagus may be advantageous, because can give us the possibility to see, when you ventilate this patient through the helmet, of some ineffective efforts that may occur and some delay in activating the trigger, and even more, can give us further interesting details. In that study in COPD patient, we understood an important phenomenon, because we could explain why the patient, despite the occurrence of many desynchronies, may indeed feel comfortable. Because when we measure the time during which the diaphragm was assisted and compared this time to that one under the same conditions with a facial mask, we saw that the time in which the diaphragm was in synchrony was even longer by using the helmet. So, having also this opportunity with a balloon placed into the esophagus may be very useful. What about the blood gas analysis? You know that is very efficient, especially to show that during the first 60 minutes you may have a clear-cut improvement also in those patients who are more severe, like the hypoxemic acute respiratory patients. And the group of Laurent Brochard, in a physiological study, beautifully showed that by applying different conditions, the improvement of gas exchanges in terms of PaO2, VO2, and PaCO2, also in hypoxemic patients, is really clear-cut. But this is also applicable in the real life. If you look at the survey that was done in France, the presence of a low PaO2, VO2 below 200 in a general population that received non-invasive ventilation gives us an important message, because all those who had a lower PaO2, VO2 were indeed the category of patients that was more prone to fail. And if you refer to a general hypoxemic patients with very different failure rate, the multivariate analysis tells us that if your PaO2, VO2 after the first hour of application of non-invasive ventilation does go up, these patients probably will fail. And even more, if you refer specifically to the most severe categories of the hypoxemic patients, those who were affected by RDS, you can see that this is another time a good predictive value for predictive failure. And this is not true for the respiratory rate, for example. And the PaO2, VO2 not going up to this cutoff in the RDS patients representing an increased risk by 2 times and more. But having the blood gas analysis can allow also the comparison between different kind of interfaces, monitoring the efficiency of these interfaces over time in correcting the gas exchanges, namely in this case the PaCO2, showing, for example, that if you compare the helmet to the mask in COPD patient, this is certainly less effective. What about the work of breathing? This is absolutely interesting. And again, the group Laurent Brochard in the same study that I showed you before beautifully demonstrated that by using this semi-invasive approach, the presence of this tube of the esophageal balloon in hypoxemic patients can beautifully show how the application of non-invasive ventilation may reduce the work of breathing in terms of pressure trying product, for example, when the combination of pressure support and PLEEP is applied. And the graphic representation of the reduction of the inspiratory effort and consequently of the work of breathing of these patients is beautifully demonstrated by these graphs when the combination of pressure support and PEEP is applied. And indeed, again, these could be very useful to compare the situation with respect to spontaneous breathing and the high flow independently which the devices you can use. So having a balloon, even though it's in large part unpractical for these patients, may be certainly useful. As said, having a new device that allows the combination of enteral nutrition and at the same time measurement of the esophageal and gastric pressure may be the solution. Then there are other kind of monitoring systems, the subjective, objective, and clinical. In what concerns the subjective response, if you refer to the dyspnea score, for example, or their comfort score, or the mental alertness, one of the examples that show you how the things can work in this semi-quantitative approach may be just giving to the patient a visual analogical scale, and the patient can just mark where he feels or if he's comfortable or with what is his level or her level of dyspnea. Or you may adopt other scales that are quite popular amongst the pneumologists, like the Board dyspnea scale. No question about the fact that if your patient is within the ICU, having right away the respiratory rate, the blood pressure, and the pulse rate may represent an option. And certainly, I suggest that at least for the most severe cases of patients treated non-invasively, having these parameters is essential. But we have also a clinical approach. Please don't forget that these patients need to be approached with a sort of art. You have to stay at the bedside, you have to speak with these patients, you have to evaluate patiently and carefully many different things. And these are other examples, are very clinical, not nothing to measure precisely, but just to testing the comfort of the mask or the air leak or the secretion, or if the mask is fixed too tightly, causing necrosis like this may be important. And several times, I remember in different lectures that Laurent has given, has mentioned the importance of monitoring clinically the sternocleidomastoid muscle contractility and contraction that depicts in a way or another the amount of effort that the patient may apply, and as well as you have to monitor the paradoxical abdominal motion. Another problem that could be taken into consideration is the idea of gastric distension, but this is strictly dependent on what is your approach. If you place an NG tube in your patient, this is very rare, and only in very few situations may occur. But if you don't, probably also monitoring the presence of gastric distension can be important in order to avoid complications such as vomiting or having inhalation. A totally another story, and I put this slide here just to mention that this is another world, that if you refer to non-invasive ventilation as a mean to deliver home ventilation, then you have a number of other monitoring system and considerations that you have to make. For example, just better focusing on the sleep and quality of this patient at home. This is my last slide, that is like the first slide, to give you the message that probably the solution in a system that helps our patient in a very clinical way. The best option to monitor these patients is a combination of the different possibilities. A physiological possibility, measuring something that ideally would be also the work of breathing, a subjective, objective, and clinical. Thank you.